Good morning, everyone. Sorry for the delay, but we're ready to get started today. So welcome to our second monthly Treat IR live case. We're here from Mount Sinai, New York. To my left is one of my partners, Dan Shilo, and we're going to show an interesting case today of a filter removal, but it's a bit more than just a filter removal. It's a bit tilted. Raj, the other Dr. Patel, and Dr. Nowakowski and Dr. Puneet Rana are going to introduce the case shortly. Just a bit of housekeeping. Again, we want to thank our sponsors or our partners from BroadMed AV, as well as Backtable for helping us get these cases up and running. And you have anything to add?
Let's do it.
Yeah. All right. Raj, Scott, and Puneet, you guys ready? Oh, also, sorry, I forgot one more person. We have Mona Ranaday also joining us on the Zoom from Mount Sinai. Who used to be at Mount Sinai, who's now at UCLA.
Mount Sinai.
She's moved on. Oh, wow, she's wearing the Mount Sinai swag right there.
I want some swag.
Exactly. So now she's IR extraordinaire at UCLA, and she's going to help us give some commentary on the cases. So again, back to Scott and Raj. If we can show them. I think they're furiously working. So there's Dr. Nowakowski, the other Dr. Patel, and Dr. Rana, who's sort of hiding there in the corner. And so actually, while Raj and Scott keep the case going, Puneet, you want to introduce the case?
Yeah, definitely.
Let me just grab that glide for us.
All right. So I'm presenting a case of a 62-year-old male with IVC filter placed in October 2023, who's here today for a retrieval. He has a past medical history significant for HIV, hyperlipidemia, hypertension, fibromyalgia. Social history includes tobacco use, substance abuse, and also alcohol abuse. No known allergies. In regards to the history, he was admitted back in October for shortness of breath. He was found to have a right upper lung cavitary lesion and intermediate risk submassive PE. Patient was started on heparin drip. Hospital course was unfortunately complicated by submassive hemoptysis requiring bronchial artery embolization, which resolved post-embolization. And then hospital course was then further complicated by rectal bleeding. So multidisciplinary discussion with the PERT team resulted in consensus of placing an IVC filter. Patient underwent transfemoral option IVC filter placement on October 9th, 2023.
There you go. All right, let's get that snare.
Prior to discharge, patient would then transition to Eliquis. Currently, he's tolerating anticoagulation without any further episodes of bleeding, so he was referred to us for evaluation of IVC filter retrieval.
Just this straight up, right?
So the initial imaging shows infra-renal IVC filter that was placed via transfemoral access on 10 in March 2023. Sorry, in October 2023. Approximately, there was 19 degrees of tilt in relation to the IVC. And non-invasive imaging, CT venogram was obtained that demonstrates no caval or IVC filter thrombus. There is angulation of the filter with concern that the tip is embedded in the IVC and like the medial wall of the IVC. Here are some coronal and sagittal reformats that kind of demonstrate the IVC filter position.
We get a 12 French sheath, 1230.
So assessment and plan, this is a 62-year-old male, history of PE with contraindication to AC due to hemorrhage, status post-IVC filter placement. Patient is now tolerating AC without further bleeding. So the plan today is for IVC filter retrieval. Considerations for him in particular are this filter has been in for at least 6 months now, and there's approximately 19 degrees of tilt, and the CT is concerning for an embedded hook. So we'll stop the PowerPoint here.
Thanks, Benita. I think Raj and Scott are still working to get everything set up here. So
Yeah.
Dan and Mona, both when you guys, so obviously we have a not necessarily a filter clinic, but we try to take a lot of care in making sure any filters that we placed, we put the note into the chart and stuff, and try to get them to follow up. But when they do come to follow up, what are you doing for pre-op imaging or anything like that, especially in someone who's on Eliquis or not on anticoagulation?
Yeah, sure. I mean, there's a lot to talk about in terms of. Oh, go ahead.
I was going to say at UCLA, we have monthly filter clinic meetings before the patient even comes to clinic, where we triage all of the lists of essentially of patients that have had filters either placed or retrieved. And we kind of document on a monthly basis in this Excel spreadsheet all of our lists. And then everyone that got a filter placed gets triaged into the bucket of straight to procedure for removal if it's uncomplicated. If it is complicated, then they need to be seen either by NP clinic or a physician clinic. And so we kind of also segregate the patients based on complexity into, should they just be seen by an NP to make sure they understand what's happening and are anticoagulate. And then the ones that come to the physician clinic typically are someone that's going to require a little bit more of, retrieval, forceps filter retrieval kind of discussions. And so all of that goes into play before we bring a patient back. So there's majority of the patients that we see as physicians will end up requiring.
And can you talk a little bit more about what you consider complex, when you think it might be complex? Okay. Like, what are your hard cutoffs for? Usually, like, if somebody, like a sample hard cutoff for me is if somebody else has attempted retrieval, I will almost always, unless I have like those fluoro images and I'm really confident, I would get a CAT scan. What are some of the hard stops for you in terms of complex, and you would get more imaging?
I mean, majority of our patients are, someone's that that we're seeing may have a history of cancer, may have had bilateral lower extremity DVT at some point. They might have had, prior filter retrieval attempts that have been unsuccessful. So most of these patients come in with some sort of history of having venous symptoms, so venous hypertension. So we usually work them up with a duplex ultrasound of their legs to make sure that the veins are actually open, or if they're not, then we want to know that. If someone is a candidate for reconstruction, we might have that conversation with them at the same time. And then we want to also understand what their essentially history is in terms of where are they in their cancer treatment journey. I guess if someone is a neurosurgical candidate, should we be taking this filter out right now, or, are they ever going to be able to tolerate anticoagulation, things like that. So essentially, CTV for anyone, like I said, anyone with history of cancer, anyone with prior DVT, anyone with prior retrieval attempt, anyone that's had filter for greater than a year, anyone that has a tilt on their filter that we think is, the hook might be embedded, or if there are extruding filter struts, they're all getting CTs. And then unless they're truly just, simple retrievals based on when they got placed, which is, we don't see a whole lot of that. So.
Yeah, I'm the same way. I have a pretty low threshold to get a CT. I think more and more, medicine in general is going towards, getting a lot more axial imaging in terms of pre-op for these things. Filter retrieval, obviously the clinic visit is really critical. If somebody's coming in, as soon as I stop my AC with the filter, I had really bad leg swelling, that's something you'd really want to investigate further. So just getting a CT venogram can save you a lot of trouble. Obviously we have, thrombectomy technology, which will allow us to really treat things in real time, but going into it, that allows you to, talk to the patient and prepare for things, in a way that you otherwise wouldn't be able to.
Yeah, again,
and then you also for clot burden, right? Like if there's any clot within the filters, are you guys, making use of any of those distal embolic protection and then retrieval at the same time, or do you just anticoagulate and then bring them back?
It depends. I think for if it depends on how much clot there is. If it's just a little bit of clot like hanging off the top, we'll, if they're not on anticoagulation, I'll put them back on for a short period of time and then rescan. Although I find invariably the clot's still there. It seems like it doesn't really get rid of it, but that's sort of what the textbook answer is to try the anticoagulation. If it's a lot of clot or the filter's obviously occluded, then I don't think AC is going to work, and then we have to sort of work through as an occluded filter, a truly occluded filter.
Yeah, I mean, I think we're in a kind of a brave new world here over the past few years. There were kind of the guidelines, if you see something, send it back, AC for weeks. But now with large bore thrombectomy, we have at least the opportunity to kind of act a little bit more proactively and kind of and treat these things a little bit more aggressively. But again, I think it comes back to like being prepared for that and really knowing what you're getting into.
Go ahead and just grab it now.
The pre-op imaging is really critical for that. In terms of embolic protection, Mona, or are you going to be doing, you think, just the newer sheaths that come with embolic protection, discs, half open stents? There was a time. Like, what's your go-to?
I mean,
I've tried the Protrieve, and it's kind of difficult sometimes because technically you can't really put the forceps through the Protrieve sheet. I mean, you can, but I'm biased. And then also I feel like with the Protrieve sheet, you need at least 5 centimeters of landing zone above the filter for the Protrieve to actually sit. And then I feel like it's quite different angles. Especially if there's a tilt on the filter towards the left, which commonly there is.
We can try with the Benson while we're waiting.
Right, it sort of
try with the Benson.
Makes it more difficult at times to get at the filter, especially if you're planning on using a forceps. So a lot of times I'll just put up discs above at the level. Yeah, I haven't made use of half open stents quite as much as I have.
Probably more a historical thing than anything else, right?
We use it every so often. Yeah. So back to the case at hand. So Scott, Raj. So so it sounds like, looks like here you're trying to do a hangman technique. So what's your thought here on what you're trying to do here?
Yeah, welcome everybody. Just want to talk here while we're working on this. Exactly, since, just like I think Puneet had mentioned, we actually felt that this is a complex, or classified as a complex retrieval because it is embedded and slightly tilted. So we thought we would go right to one of the complex, one of the maneuvers that we use for complex retrievals, which is, the loop snare or hangman technique. So we, basically forwent the the standard snare technique, and hoping we can just get enough of this. But that the apex and the hook are pretty embedded in there. So
do you guys want to talk a little bit about your setup, kind of what the thought process was for that, your sheets, or how you chose sizes for everything?
Yeah, so okay, thank you. Yeah, so I think that it's a good idea for these to go ahead and do a jugular approach to first, obviously we can also consider doing a femoral approach. And actually what I like to do is just go ahead and do a jugular approach, but have the groin prepped. And so we have that here. And then just do a cavogram and really get a sense of, let me just see if we can just grab this wire. I'm going to just, we're going to just try to see if we can get a sense of whether the standard technique is going to work and give it some time. And then obviously we have an escalation of techniques. And so we're sort of on what I would call from the first to the second step, which is to go from the standard snare to the to the hangman or loop snare technique. What does the panel think about the success rates in these kinds of patients with the hangman technique? Does the panel think that they think it's going to work most of the time? What's been your experience?
So I've been going more and more to going to forceps. I mean, I think we have a lot of tools, and just I find more and more I'm just going straight to forceps and trying to angle it. In terms of your access, I think we had talked about accommodating that. We had been talking before. I think most of us are using some version, depending on how big we need to go, from like the 1645 or 1840 hooks, and then up to the 20 centrants if we have to. and that accommodates that. And like I said, I'm pretty quick to forceps.
Yeah, same here. I'm
Me too.
fairly quick to go to forceps just because ultimately
Yeah.
I don't find the hangman works all the time,
Yeah.
or sometimes I end up getting the wrong part of the filter and ends up making it a bigger mess. So I have a low threshold to
Yeah.
go to the forceps for these types of filters. Now I think for other types of filters, I think the story's a little bit different. So I think for the sort of optes, trapeze kind of thing, or even for greenfields, just because you can't necessarily get enough grip with the forceps.
Yes.
It's usually a combo technique of using hangman and forceps. You may need both techniques
Yep.
to get it to work. But how about you, Mona?
Yeah, I think same. For these type of filters, I would probably go to forceps within the first 5 minutes of trying. But I do think that, I have had patients where I have not had them under general anesthesia and they have reacted with the forceps. And sometimes it just really, you could be in there with the forceps kind of just even every movement the patient realizes, then at that point I have, attempted to try and just do it with the hangman technique. And it does kind of work to try and peel that filter basically towards the center of the cava. A number of times. It just takes a lot, I think, of patience and
Try it with a contra too.
perseverance.
A contra.
Yeah.
Well, now that you're
Contra too.
UCLA, I think you have to use hangman a little bit more,
try it.
right? Isn't that kind of obligatory?
Let's try it.
But yeah, I mean, I think it, like you said, it depends a little bit on the filter type. Some of them you're going to have that closed cell portion, so you can't necessarily go all the way up, and that could actually tilt it a little bit more. The option specifically, unless you want to go into the closed cells that are at the top, it could be difficult. Whereas other types, like a select or anything where you could hangman all the way to the top, it might be, yeah, a little bit easier. I think for me personally, I think having a timer on is really important for me because sometimes, forth from the weeds. I'm sure others are somewhat like that as well.
Yeah.
Are you guys
I
getting
mean,
femoral access at the same time for most of these, or you kind of just prep it and get it if needed?
I sort of prep and hope for the best. So it's ready to go, but usually I would say most times we're able to get it from the top. Sometimes if it's really embedded or really hooked, it's sometimes a bit tricky. It always comes out from the groin, but it's always a bit nerve-wracking pulling it out that way. Yeah. And again, I think Mona makes a good point. I think we have a very low threshold to use general anesthesia for these cases. Obviously, the more complicated it looks, the more likely we are to use general anesthesia and go from there. As Mona said, the patients do really feel the forceps, and it's really hard to predict who's going to feel it and who's not. And some people react very badly to it.
Do you find that helpful at all? I know, so at meetings, especially a couple years ago, a lot of folks were saying they kind of enjoy not having the GA because they get a little bit of feedback. So if somebody reacts, I don't really find that helpful.
No.
Some folks were saying, people that were kind of experienced operators, if they're reacting more than I would expect, then maybe, I'm doing something I shouldn't be. I don't personally find that helpful, but
I haven't run into that
yeah.
yet.
Yeah, same.
Yeah. So Raj, just in terms of your setup, in terms of doing
Yeah.
the hangman, so it looks like you're using a reverse curve catheter. You switched to, it looks like switched to a sauce just to give you a little bit more control
Yeah,
over the
we
wire.
switched to a contra here, and I agree with all the comments about the hangman, but in particular your comment, Rahul, about sometimes I find that even when we can successfully sort of accomplish this hangman, I find that you wind up sort of pulling up on one of the one part of the filter, one of the legs comes up, and instead of really pulling the hook cleanly off, and so which is what we're obviously trying to do. Yeah, I'm just going to get this down a little further. Yeah, this so I like to use a glide wire and a reverse curve catheter, just like you were saying, and then just grab it and then just form that loop snare and try to see, just having a little.
I don't know if you mentioned it. You said you have what size sheath do you have in the neck to start?
Well, we have a 12 right now.
Okay.
Because we have the 6 French gooseneck snare, and I mean the tri snare, excuse me, and then we have the 5 French, contra, to get us. So let's see if we have it here. I think we might have it here.
I think you're close.
Yeah, just spin that and oh.
Really important for these to use a glide wire, not use something like a Benson or implants or any steel core wire, because you can definitely
yeah, exactly.
So I just want to make that point for anybody who doesn't have experience with this. Yeah.
And again, I use a floppy glide as opposed to like a stiff glide, right? So it doesn't
Mhm.
less likely to flip out your
Yeah.
sauce. Yeah. Have you used, just out of curiosity, have you used the tip deflecting sheaths at all? You guys
Well,
had any
that's
experience with
interesting. I have not. That's very
Yeah.
interesting.
No, I haven't done it for these.
Yeah. Like the Oscor sheets. Yeah.
Right.
I know people have talked about it just because you can just hook it and just sort of drag it back.
Thanks.
And,
No, it's a great idea. I mean, I've used like angled guides to get a little bit more angulation, but not a tip deflecting sheath.
yeah. Tip deflecting sheaths. I've used a tip
Yeah, I
deflecting
think,
What about
glide.
laser?
Yeah.
Are you
What
guys
difference is
using
this?
laser or considering laser?
So we don't
What
use the
difference is
laser
this?
really that much or at all. We just sort of use brute force. We're sort of,
Well, you still have to get around the hook in
yeah,
order to use
exactly.
the.
Yeah.
I think a lot of these cases are you
Yeah.
still, need to get it
Okay.
kind of
Yeah.
attached on the embedded portion.
I haven't found a lot of need that I was like, oh, if I
just
had the
spin
laser, I
that.
would have gotten this filter out. I don't know if your experience is different. Usually we just sort of pull really hard and it comes out.
I mean, I think one of the big benefits of the laser isn't necessarily to get things out like you're saying that we wouldn't otherwise. I think it allows you to do it with a little bit less force.
Yeah.
But I think, I think with experience, you kind of get a feel for, it's kind of what we were saying about feedback from the patient. I think over time you get a feel about what feels right and what doesn't feel right.
Yeah.
And you can kind of change around what you're doing if it really doesn't feel right. Mona, how's your experience with the laser been? What's good? What's difficult?
I
Okay,
haven't
pull it
really
in.
had much success there either. I think, like I
All
said,
right.
it's, I think a lot of times the tip
For the first try.
is very embedded or very tilted,
Yeah,
and you
we got
need
the
to
wire,
straighten it
guys,
out.
so we're gonna try
Yeah.
to pull back
So
on
it
the
looks like we
hangman
got
now.
it here.
Yeah.
And let's see if we're just going to mag this up and let's center this so we can see
Make
what
sure
we're
it's
doing
tight.
here. A
Make sure it's
little bit
tight.
better.
Make sure it's tight so it doesn't pull out.
Any questions?
Here we go. Let's just see if we can just grab it here
Yep.
and maybe at least displace it.
Yep. See it's straightening a little bit and
Okay. What we're going to have to do
pull
is
the wire.
actually go ahead and feed that in.
Okay.
Just so you have it there.
Yeah, it's coming.
Okay. Yeah, I'm going to just see if we can maybe
Use the
once we
wire.
have it, get a little bit better.
A lot of times in these type of cases too, I'll use a larger sheet because as we're seeing here, sometimes you'll get the neck of the filter to come in and then the hook is still kind of sitting outside of
Inside the sheath. Yeah.
so that you can kind of oversheath it with a larger
You got it?
Yeah, I was actually having this discussion with my fellow yesterday. I was like, like what size sheath to use, and I was like, what size sheath do you want to use? And he said 16. I'm like, all right, great, go 18, because it's always you always feel like you're one size too small.
Let's grab
So
this
just-
one.
Yeah.
And then I'm
Just
going
go
to
one size
change this
bigger.
out.
It's a vein. It'll 16 to 18 is not a big deal,
More forgiving.
Funny
Yeah.
how we think alike. Well, it must have been that
So
you
we can
trained
get
me or
I
something.
must be. It must be.
Go big or go home.
Yeah. Yeah. I mean, we've definitely been burned, especially because the sheaths that you have, the different sheaths you have from the neck are somewhat limited. I mean, Argon does have a new sheath, which we haven't used, that dual lumen 16 French sheath. I haven't used it yet, which is a little bit more reinforced in an appropriate length for doing sort of the jugular work. But for like if you want to use forceps from the neck without that sheath, you're sort of limited to the Cook sheath, and that sheath's not really reinforced. And
both.
we've had it strip and tear and get stuck in very bad places. So from the groin, it's not such a big deal because you can use the lengths aren't as big of an issue. So Raj, what are you doing here?
Yeah, so look, I don't know if you can see this, but you
Another
see
glide.
we have the glide. It's a 180
Okay.
glide.
Right.
And we've
least
taken
that's
out
that,
we've basically
Oh,
obviously
that's
pulled the
so
wire out using the
the
tri
scissors
snare. And
come
so
out.
we have one end here, and then we pulled out the contra also. So now all we have is just the wire, the nitinol wire, so it doesn't kink, of course. And now we're just ready to go ahead and see if we can just basically just get this off of the wall.
Mhm.
And Raj, in terms of your setup there, so it's exchange length or it's 180, your glide wire?
It's a 180. It's a
Okay,
180.
and you have it clamped
So
on the
extreme.
ends, like how do you?
Yeah.
Usually
you
we
see
like
it
to
here?
just, if you can show,
Puneet has them
if you
both
just
here.
want to show folks, if you can zoom in on the camera, just kind of how we clamp them.
Yeah.
It's kind of a standard thing we do for any type of snare, but it gives you a nice handhold on it as well.
Yeah. Can you see it?
Just
don't
just a couple
think
forceps
I
down
have
there.
the-
You can use anything.
Good.
Yeah.
Good.
Cool.
Oh, okay.
All right.
Just don't use
Yeah.
the scissors.
Yeah. Exactly. Okay, so look, let's see what we can do here with getting this off of there.
Yeah.
Okay. See, this is the thing with it.
Right.
We
It's so
created a
embedded. It's
horizontal
sort of,
platform to
Yeah. Now
use
we've made
our
it just like
forceps.
you were saying earlier, Rahul, and
yeah.
yeah. So it's just like Scott is saying, it's horizontal. So
Yeah.
yeah.
It's a
all right,
little
what
hard to predict
should
which
we
way-
do here?
Yeah, it's sometimes, like I said, it's a little bit hard to predict exactly which way that thing is going to cantilever and turn, right? You hope it flips the nose, the cone of the filter to the right, and a lot of times it just tilts to the left, and it gets worse. So yeah, I think at this point you're sort of stuck, right? Like you're going to have to go to forceps here, sort of give up the loop snare.
Yeah.
Yeah.
So I think that's what we're going to do. We're going to go ahead and just, Debbie, could we trouble you for that 18 French sheath? So, I think we're going to have to go here now to the. Is anybody in the
18
panel think we
18
should
French sheath.
continue with this?
Yep.
Because I just think that we're going to actually just wind up making it even more sort of distorted and disrupted the filter itself.
Yeah, I definitely
I think
going
most
to
of us would
forceps
just
here
go
would
on.
be the way to go.
And
Yeah.
also,
Yeah, I think most of us
Okay,
would go
good.
on as well. Yeah.
Yeah.
fix that in a
So,
moment.
while we're getting the sheath and, I just don't know if, can you see this or can the camera, face this? Can the, I don't know if,
Yeah, there we go.
the camera can, there we go. Yeah, so, let me see if I can just show it here. So this is the Limol, forceps, 4162, and this is it has the white handle, so this is the one that we want. It's 60 centimeters long, so you want to make sure that your sheath is 40 or 45. You don't want to have the sheath be too long. It has a 3mm shaft, and then the jaws themselves are about between 4 and 5 millimeters, and then it has this sort of alligator teeth, and has this articulating arm, which you can control with the with the handle here, and then it has this sort of more straight arm. And the idea here is to get this in there, and then to just sort of turn it. I mean, the technique is basically to turn this and sort of, displace the tip of the filter off of the wall, off of the cable wall, and then go ahead and, of course, grab the apex and the hook, which probably in this case has some, an endothelialized tissue encasing it. So that's what we're going to be doing here. And, these will go through a number of different sheaths, but we like the 18 here.
Exchange it out for that.
Go ahead.
So, Raj, I know we talked about a little bit this earlier about there's different pitfalls and things that can come up with the forceps, right? So one thing obviously is they come straight. So the straight doesn't usually work because you got to get it off the wall. So we put a little tilt on it. Yep, they're they can be sterilized, so we can use them again. One of the big issue we have right now is don't throw them away because you can't get them or they're very hard to get. So we have our certain number. They sort of lose their grippiness after a while. So we have a couple that are not as gripped as others.
And I'll do some. Okay.
Mona, are you able to get these forceps, or they're still sort of back order for you guys as well?
Same. We keep ours very safe.
Yeah,
it's a very hot commodity nowadays. It's really somebody should put air tags on all of these in case they get thrown out at the end of a case. We have to go get them. So if you have these at your institution, do not let them go because they're very difficult to get now.
Yeah.
So Raj, you said you're going to go up to the 1840.
Yeah, we're going to exactly.
Okay.
The wire is a little bit trapped in the filter, so we're just going to actually need to sort of disengage it a little bit. So we're just going to get a catheter down because it doesn't want to just sort of slide off so easily. The loop, I think, is just.
Simona, what sheath do you use if you use the forceps from the neck?
I'll typically go with a Gore dry seal, a larger one like a 20 or a 24, and then put a 16 through it. But I tend to do the dual sheath technique to get over the embedded or tilted hook.
Yeah, you do that just so you can get the You can just rip it the whole thing, invert it into the sheath.
Yeah.
Yeah, it's not a bad idea. Yeah, my concern with the dry seal, obviously you put the 16 French through, is that you're going to tear the valve coming through, and then it just becomes a mess. Yeah.
Well,
Yeah, I think
that's
that's a
why I
good
have
point
the.
about. Go ahead, please.
Oh no, I
A
was
good
just saying
point
that's why
about
I have the
whether
16
to use
French
one or.
since it's not as bad.
Yeah.
We don't have the Centron sheets as much at UCLA, so they're not readily available to me.
Yeah, the ones
so.
the Centrons don't come in long enough, really, unless you have a very short patient, to use them from the neck. They work well from the groin for doing like the inversion technique, but from the neck, they're a bit tough.
Yeah, the few times I've telescoped, putting something 16 into 20, I don't remember really ever being very relieved that I had it telescoped, and I have once or twice run into a situation where it was actually a big pain. It got me into a little bit of trouble. So I've kind of gone, once I'm going forceps, I've just gone to either like like we said, the 1645, the 1840. I've actually found in tall patients that extra 5 centimeters in the 1645 can be helpful.
Yeah.
And then, yeah, from the groin, if we're doing filter reversion, which we can talk about a little bit later, that's going to be usually a 20 or often a 24 Centron for that. All right.
Nice.
So it looks like they're making their way down. This is the 1840 Cook.
So actually, it's one thing we didn't talk about. Raj, did you hold the anticoagulation for this patient, or did you just keep it going? Because now we're gonna sort of more rip this filter out as opposed to.
Yeah. No, my protocol has really been to just keep these patients on the anticoagulation, and I just leave them on the anticoagulation, obviously, during the procedure, and even afterwards, I ask them to continue it so that, we can basically, we just don't want, obviously, things building up on our system, clot and all, so that's why, and I like to leave them on it. And even if they're not going to be on it anymore, I do leave them on it for even another 2 weeks afterwards. Yeah. So can we just go to the slides for a second? So, Dr. Nowakowski is now going to be getting our snare in, and you can see, our forceps in, and and he's going to use that technique of just opening up the jaws and then rotating until he can.
Actually, why don't we just show the
displace
case?
as much of it?
Why don't we show the case?
Yeah, I want to get a little closer. I think I have it at the base, but I want to try to get a little closer to the hook there.
Can we stop showing? Yeah, there we go.
Just sort of, I can see.
Yeah, there you go.
So
basically,
you're
using
more, please.
So the trick is like you will use both visual and tactile feedback, right? You're kind of feeling for the metal, right? Sort of click into the forceps, and you're trying to grab it
the other way.
Yeah.
So I'll go the other way, Raj.
Yeah.
A little more. Okay.
Actually, if it's not going to interfere with your case, do you guys mind zooming in a little bit, just for because on the screen it's not quite as large.
All right. Awesome. So just.
How's that? Is that better?
Yeah. Yeah, that's great.
So that, as you can see, I probably have some wall here or some fibrosis. I'm not around it, but the filter obviously is moving, right?
And so one of the benefits, I think, because it's an optional lead, it's a single cut nitinol, and so if you do have to ragdoll it, if you do have to kind of grab it in the middle and get into the sheath, it'll be more forgiving in terms of coming apart, I think, than some of the more previous welded filters.
That looks.
Ragdoll.
I like that.
I saw a picture of Steven Tyler getting history with that wonderful mustache that he has. Don't know what to do.
I think it provides me, probably falsely, a little bit more comfort if I'm doing an E version. I know I have single cut nitinol, then it makes me feel just a little bit better.
Yeah.
No, there's no doubt that if it feels from below and just inverting it is really might even be viewed as being easier. And again, I'm still just next to it.
I guess coming from below, where you're coming right at the.
Yeah, you just come right up into the apex.
Right at the. Yeah, exactly.
Yeah.
That makes, but just like you said, just worry if it's gonna fracture. The nice thing about or having the forceps, if it does fracture and there's a strut that's sort of left in place, with the forceps you can usually go back and just pull that out, so you get the whole thing out. Pull it out hopefully before it embolizes.
Just trying to go in a little 360 here to see what the best angle for this puppy is.
So one of the questions from the audience is, do you guys ever use biplane for forceps removals, just to help with sort of the angulation questions and stuff?
Biplane would be super awesome right now, but we don't. No, I have not used it.
Yeah.
But yeah, you can see how it would be helpful, right, in regards to.
Is that we don't necessarily have readily
If this-
availability to biplane.
Yeah, I think
One
if you have
view
it
is no view, so-
reliably and regularly available.
Ha!
Yeah.
That's why we've been sort of angling the tube a little bit every so often.
Yep.
Let's just get to right
There's
here.
also some considerations with biplane, having anesthesia there, and you're working at the head, and
Yeah.
like, just,
It gets really busy really fast.
limited real estate.
Yeah. I don't know how your rooms are on UCLA, but our rooms are tiny, as you remember.
Yeah.
Yeah.
We have more. We're LA. We have more room.
Real estate is cheaper, right?
Oh, it's not crowded at the-
You can have a lot of space in the room.
Yeah. There you go.
So this,
Yeah, promising.
yeah, that might
Good.
be. Oh, you
Yeah.
can see right down the barrel there.
Yeah.
Definitely.
Yeah.
All right, all right.
Like a mama tiger getting her cub, just by the neck.
Yep.
And now it's just brute force, right?
So I think
Okay, so what I've actually done is I may have
You've split
Yeah.
the
Yeah,
filter-
that's-
yeah.
sliced the sheath a little bit. All right.
yeah, I think the sheath might be a little bit.
Right.
And I have seen that happen with this sheet before.
Yeah.
Like,
You have?
Oh yeah.
yeah.
Because it's not reinforced, right? So
Okay. So one of our options here is to just pull.
I don't think that's a good idea.
No, it's not a great idea. But again, I don't know how we're going to.
So
Or
I
just
think
push
what
it
might be
out and then
lower,
grab the apex.
Straighten it out.
Well, this, okay. So,
And now that it's come out. if
Yeah, you may
just were to
so let's just see here. Okay.
yeah,
Yeah.
So let's just see here.
out.
Start.
you may end up
Right,
having to
leave
take
it
it
go.
out just from the groin, right?
Yeah.
Yeah.
And just invert it.
Still another way, yeah. Or if you just let it go and then just try to
I feel
reposition
like
the
you
tip.
could, let it go and kind of walk it so
You
that
think it'll
it
fly?
straightens
Yeah.
out.
It won't fly.
Yeah, you might be able to try to walk it, to get
Yeah.
the hook,
I don't
If you have
let
more
go
of the
this one,
forceps
but-
out of the, yeah.
Yeah, I don't think. But the
I
thing is, I
think-
think it's so tilted, it's not going to
Yeah.
straighten, right? Yeah, and I think your sheath's so buggered. Yeah, I don't think it's going to work. I think you're going to have to do it from
Yeah,
the
the sh-
groin.
Yeah.
See a little higher up, please.
Yep.
Yeah, I wouldn't drag it too high because you're never going to be able to get it from the groin, right?
Yeah.
Yeah. Oop, where are you going?
So one of the
Now what-
important things with these is, once you have it kind of free like this, you always want to be very, very cautious. I would almost say do not let go of the filter at this point.
No, I concur. I mean,
Yeah.
do we have a second set of forceps?
But
We have another
we
forcep,
can,
right?
Yeah,
yep.
let me just check with Debbie.
And if you want
Yeah, if
to,
we go-
you're in a position right now where you have a hold of it. It's not going to go anywhere. So you can always kind of come from below. You can always grab it or even snare it just for
Yep.
stability.
The forceps.
To make sure it doesn't fly.
Yeah.
It's always an
Agreed.
option. So you're in a stable location right now with a good hold on it.
Maybe we can.
I don't
Yeah,
think we have
although
a
I think right
second
now it's
forceps.
pinned. Right now it's sort of pinned, right? You could use the
Yeah.
other sheath to pin it. Although now,
So are you guys gonna try to go from the groin, or are you guys gonna? What's the thought process now?
Let's get up from the groin.
Yeah, I think
Raj.
Yeah.
I think that's the best way. Is just go
Yeah.
ahead and just we have the groin prepped.
the other thing you
and
could do
we're
is
just
if you
gonna
don't have
go
the
ahead and get
forceps, is you
into
could
it.
hangman it from the groin and just
Yeah.
grab it, right, and then get the forceps, put a 20 French
Right.
on the thing and then
Right,
grab
yeah.
it, right, to pin it once you can let
Yeah.
go of it. Yeah.
Well, I think the plan was always to do dueling
Yeah.
forceps. This was just kind of our opportunity to do it.
To show how shitty the how
Exactly.
bad the cook sheath is.
I mean, this is exactly how we drew it up. I mean,
yeah.
Yeah. I guess, does anybody think that some of the other sheets, this may not have happened where it, sort of,
I think if we had
gets
done
sliced.
Mona's trick with the gore, it might have not tore the sheath because the gore is pretty tough to shear like this. The cook sheath's pretty thin.
yeah, I think that's kind of what we were talking about before, where there's limited options. I think the centrant is a lot stronger, but like you were saying, you just don't have the length. I think 28 is the longest it comes in, right?
28. Yep.
Yeah, so you wouldn't really have the length.
Yeah.
And like I was
That's
saying,
right.
even the 45 over 40 can be helpful in taller patients. So the centrant just isn't going to get you there unless you're coming from the groin. I mean, there are really outside the box ways you could try to do something from like the left neck if you were going to snare, but I really think that the best way to try to at least
I think
stabilize
Scott's
this is
trying
going
to
to be from
straighten
the
it
groin.
out right now. Oh, it's
There we
straight,
go.
it's
There we
straight.
go. Yep. Yeah, we got it. I
got
let.
it?
I got it. Okay.
Oh, nice.
Yeah. So I let
also the
go
threat.
and exactly. No, I actually let
Take
go of it
that.
and then grabbed it closer to the hook
All right.
Yeah.
and the archie
Excellent.
blows.
Right.
Hey.
Nice job,
Strong
Scott.
work.
There you
All
go.
right. You want to save that fluoro and show it
Yeah.
and kind of, Scott, you want to talk
Yeah.
through kind of what you did there? I think it's really important to kind of talk through what you did there and how you got yourself to a position where you can get
No,
that
absolutely, absolutely. So I mean, obviously the issue was the fact that we had
Can we play it?
filter on either side of the graspers that was acting as sort of this cutting device, right, with the sheets. So I just let go of where I was, which is about half a centimeter from the tip, from the hook. And I just sort of angled a little more, grabbed actually the hook because it was in a better position to grab. And then it sort of converted itself to just being straight and coming out as opposed to being this big cutting device. So just shimmied up to the hook, basically.
Sorry, go ahead. Yeah. Do you guys want to exchange and then you'll kind of do some runs? I don't think that sheath is going to do a lot of good work for you at this point.
Well, you don't need to exchange. You just put a catheter. You just put a catheter down, right?
We'll just get a catheter down. That's all we're
Pig
going
or
to do.
something. Yeah.
Yeah. We have the picture on the table, so we'll just get that down. So here's the filter just to show, that all the legs are here, all 6 legs. But you can see that the, I don't know if you can see it from here. I'm not sure if they can zoom in on this, but
we'll post it. We'll take a picture and post it later. Yeah.
Yeah. Good idea.
Yeah, we'll take a
idea.
picture and post it
We're
later.
able to
That's
see
probably
it.
easier. Yeah, the other thing is, again, Scott's our quality guy, so we'll talk a little bit about this. But we, one thing I always say when we do these complex filter retrievals, I always
I'm
tell
a
those
wellness guy
fellows-
too, so
Wellness too, yeah.
we're all feeling pretty good right now.
Yeah, exactly. Feeling great. So the I always, get a single shot or an X-ray of the chest just to make sure there's no legs already there, and then do it at the end just to make sure all the legs are there. Count the legs, kind of thing, because I don't want to get blamed for broken legs if it was there before I got there. So
100%.
Right.
And actually
prior filter retrievals and even wires. Prior wires can be.
Yeah.
Any filter that's a couple years old, especially if I only have a CT, I mean, you can see it on the Scout. I'll literally just mag up almost to the size of the screen and take 2 orthogonal 1Xs.
Yeah. Yeah. Looks good. That's just bad.
Yeah, there was a vein there. That's
Yep.
what that was. Yeah.
Yep.
Yeah.
Gorgeous.
Looks good.
Can we run that again? How do we run it? Yeah.
What's it like?
Okay.
Oh, there we go.
Maybe like 15 minutes.
Ah.
I think we should probably get off. It's like 10:05, just so we can stay on.
Yeah, can we just run that? There we go.
The run.
Yeah, here it comes. Can you see it?
I mean, it looked pretty good. I mean, I don't think there's
There
anything.
you go. Yeah.
Absolutely. And, anesthesia, hemodynamically, how are we doing? Thumbs up from anesthesia. So
Yeah.
that's one of the things, too, is
Most
to see how they're doing hemodynamically. Exactly.
Yeah.
And, yeah.
Yeah.
So just
go to the.
yeah, simple questions. Like, what are you gonna do, in terms of removing the sheath? Are you just gonna hold pressure, purse string, mattress suture?
Usually for these, I just hold pressure and just make sure that they're upright.
Yep.
and that should be enough for them. I think we're just going to go to the slides for a second, just real quick, and then.
And one last thing, by the way, 6 legs on here, so we always
Yeah.
photo document. Take a picture of this and add it to the chart. So,
Yeah.
And as mentioned earlier, also take a look at the lungs, make sure there's nothing there. But yeah, so we always photo document these just to make sure there's no issues or questions.
Yeah, and then you just want to show, yeah.
Yeah, so I think one of the things we wanted to just sort of talk about, I think we saw a lot of interesting things during this case, in terms of having to use the loop snare technique and then going to the forceps, but just some of the tips with the forceps, just especially when you're coming from the neck, it's possible. Just go to the image showing the forceps first, and then or even this one here is good. Is that it's easy for the sheath to get displaced into certain veins. Not sure if you can see it on the screen here, but
it's
we
a
have
beautiful
a couple
shot
of
of the
images of
gonadal,
our of the sheath sort of inadvertently once you get the wire out to fall into the and then the forceps and the gonadal too, exactly. So one of the things you want to sort of be mindful of is where your sheath is. You could certainly use a buddy wire that would help, and in some cases, depending on how big of a sheath you have, that might be useful here. But just sort of keep these things in mind. Know where your sheath is, know where the forceps are, because obviously having operator experience with this is really critical.
Perfect. Thanks, guys. It was a great case. Always more fun when they don't go completely straightforward. So, but always good to have a good result at the end too. Thanks, Mona, again for joining us. I know it's super early in the morning.
Thanks, Mona.
Thank you, Mona. Yeah.
And so again, I think the plan is next one is May 10th is the next live case. We don't know what the case is going to be yet, so stay tuned. But we'll have an interesting one, I think, for you as well. Thanks everyone for joining us, and we'll see you next month.